Dr. Riggs is a board-certified internal medicine physician and assistant professor of medicine in the Division of Infectious Diseases and Global Public Health. She has a clinical focus on patients with HIV and research focused on the neuropsychiatric effects of viral infections and associated immune dysregulation. She is a member of the Last Gift study team, this is where I pulled this from, where she conducts participant visits, data collection, analysis. She also is in the second year, I hope, of her KL2. And maybe she'll talk about that a little bit, exactly what she's studying under the mentorship team of Dr. Latender and Dr. Gianella Weibel, I believe. And she also works at the Owen Clinic, and it's wonderful to have Katie as part of the division. I'm so sorry. And she's doing a CROI rapid review for neurology. Thanks, Katie.
Yeah. Thank you. Hi, everybody. So we'll get right to it. Oops. Do you guys still see the right thing?
Looks good.
Okay. Random other things are popping up on my screen, but I'm glad you can't see it. So, yeah, I've got no disclosures to talk about today. And so
that's popping up, Katie.
What is happening?
Sorry.
I don't understand why that would happen. There, perfect. Okay, is that right?
Yeah.
Okay. So we'll talk a little bit about at least some diagnostic stuff, and I put a question mark after treatment. So there was a whole focus that was treatable causes of cognitive impairment. We don't quite have a treatment yet, just so you don't get too excited, but I will start with, I think, one of the highlighted oral abstracts here, which was from Leah Rubin and Pauline Mackey. And this was highlighting this one because it's actually a placebo-controlled trial focused on neuro and specifically cognition, and especially in women. So this was the effects of low-dose hydrocortisone on cognition in women with HIV, a placebo-controlled trial. And so the rationale for this was that, especially in things like PTSD and trauma and chronic stress, there's actually lower cortisol levels over time and a abnormal diurnal or circadian rhythm. And so it is postulated that this is actually like glucocorticoid resistance. And so this alters the immune system as well as limbic and kind of our flight and fight responses and overall other neurocircuits. And so the question here was whether you could actually give a hydrocortisone, low dose hydrocortisone, as if you were treating basically adrenal insufficiency. And this is so 10 milligrams once a day of hydrocortisone versus placebo. And this is a double-blind placebo-controlled crossover. And so it was to determine whether pharmacologic modulation of the HPA axis with low-dose hydrocortisone. So that's what the LDH in the next slide is referring to, improves cognition in this two-phase study. So this is overly complicated, but basically it's just clearly showing that everybody got the low-dose hydrocortisone and placebo, and there was a 30-day washout in between, and that there were two different phases. So there was the acute phase, which was basically looking at, they did cognitive testing at 30 minutes after one single dose, and then 4 hours post-dose. And they also they tested cortisol and then anxiety and stress self-report measures. And then there was phase 2, which is actually women were on for 28 days of once daily hydrocortisone 10 milligrams, and then did cognitive testing at the end of that. And so, interestingly, they did actually find some differences in cognition. And remember, this is all in women. So at 30 minutes post-dose, so this is the results of the phase 1, which was just the single dose. So 30 minutes, there was actually significantly associated or improvement in attention. So they measured it before the dose and then at 30 to 70 minutes after the dose. And then at 4 hours after a single dose of 10 milligrams, there was significant improvement in verbal learning and in attention. And then moving on to the sustained, so the 28-day result. So this is everybody who's taken one dose every day versus a placebo-controlled. And so at that point, verbal memory, which was similar to what was seen at 4 hours, remained significantly improved in the low-dose hydrocortisone group versus placebo. Attention, which had shown the earlier signals with the single dose, was not significant over time. And this is particularly significant because verbal fluency and verbal memory has actually been highlighted as a key domain that is more impaired in women with HIV than in men with HIV. So this could point to some of those differences that we do see in cognitive impairment in people with HIV. So between men and women. And interestingly, so it didn't improve the diurnal cortisol level, which I think sort of makes sense, even though it's a short-lived medication. There wouldn't be a reason that your body would start making more cortisol, I think. And then they did compare it to a panel of about 7 inflammatory markers. And the only thing that they did see was glial fibrillary associated protein, I think, which is associated with astrocyte activation. That was decreased. And then there were no changes in the reservoir, which was a secondary aim. And so overall, basically, it did show that at 30 minutes, there's this improvement in attention and concentration. 4 hours, you add on verbal learning and verbal memory. At 28 days, there's an improvement, sustained improvement in verbal memory. It was safe, it was well tolerated. And then I think the rest is kind of just next steps of neuroimaging and a little bit more mechanistic information as needed. And then I was initially going to go into a lot more of Dr. Shabani Mukherjee's talk, but I think that would take a little bit too long. But I am going to point you to this first. It was a fantastic name of a session. And then she does go through a very practical way of assessing neurologic and neurocognitive issues in the clinic. Some of it is more feasible than others, but she does go through some case studies and case examples. But I would say the overall theme of her talk, and fortunately or unfortunately of kind of the whole overarching theme of the neuro sessions, I think this time we're really focused on this treatable traits approach, which is also what is being applied in dementia and other diseases as well that are hard to directly target. But we've heard this before, but it's basically whatever is a modifiable risk for cognitive impairment or mood disorders, treat that. And so she specifically highlighted the vascular traits, so really controlling the hypertension, diabetes, and hyperlipidemia. And then also really focusing on trying to address insomnia the best we can, highlighting the need for sleep studies and CPAP and that increased risk in people with HIV to have sleep apnea, even without all of the traditional risk factors. And then this is very reminiscent of Miley or Dr. Karas's work on social isolation and others, that this really is something that is potentially intervenable and does have real outcomes. And so that's all I will say about that. But if you do want to go through that, I highly recommend just kind of working through, I think it's 20 minutes of her presentation. And so we'll go on to other posters and abstracts here. So along with that theme, so modifiable factors could mitigate greater burden of brain small vessel injury in women with HIV. So this is with Felicia Chow and Elena Farrell. And so this was looking at sex differences in subclinical cerebrovascular injury. And so looking at small vessel disease versus large artery disease. And so overall, this is from the Max Wise cohort. And this is everybody is on ART, 55% were women. And then they did basically just, it's mostly structural MRI, as well as some weighted imaging. And then so the key results were women had a 2.93-fold higher burden of small vessel disease. So, but there was no difference in large artery disease here. But women definitely, and this has been shown before, especially by Felicia Chow, but re-demonstrated in a different cohort that this is much higher in women. And that's when controlling for age and smoking. It was, and this actually the risk of sex differences or in women was higher when you actually account for things like smoking and age and other factors. So the sex differences actually increase at that point. And then injection drug use and higher viral loads were associated with small vessel disease in women. But interestingly, if we jump over here to the sex differences and factors associated with small vessel disease by men and women. So history of methamphetamine use or smoking was particularly noted as an increased risk in men for small vessel disease. And then antihypertensive use was an increase or a risk in women. And then a protective factor in men, which I don't think I've put the poster here, but there is also evidence that there is a differential effect of blood pressure control in men versus women in the clinic, and that women are much less likely to be controlled. So there's a theory that this association is actually just if there's a higher threshold needed to put women on antihypertensives, that this may actually be kind of a surrogate marker that means that they have worse or harder to control hypertension. And so overall, the conclusions were just women with HIV have a disproportionate burden of small vessel disease, and we need to keep that in mind. And then for
Katie, sorry. Gigi asked a quick question of, is this true in women without HIV too? But I'm not sure what she was talking about when she put it down, because there's Gigi,
the findings in general are
yeah.
Is there more small vessel and is there more small vessel injury in women without HIV as well?
I don't believe so, but I think there is at a younger age, but I think it starts at an earlier age and then the trajectory is similar, but I don't know the answer. If anybody else does, please jump in. But that is a fantastic question because this was only in people with HIV. And then, so this was the Prosper HIV study, which just improving steps in diet quality reduces symptoms in people with HIV, or adults with HIV, as just a way to highlight that, yes, the tried and true physical activity and diet are important. So they looked at, this is the self-report HIV symptom index, but this does include things like fatigue, sleep problems, and pain. And those were specifically highlighted in here as most improved with basically with walking and healthier eating. And so every additional 5,000 steps per day showed a significant decline in overall symptom burden. And same thing with higher diet quality, but there wasn't quite the same breakdown as I think it's nice to be able to say every 5,000 steps has a measurable decrease. And even if you are getting that exercise, it's still just sedentary time is also a risk, as I think we've seen with other things. But the most common symptoms were actually kind of the insomnia, fatigue, also neuropathy, and anxiety, but the significantly improved ones were insomnia, fatigue, pain, including muscle aches. And so, yes, saying exercise, diet and exercise will help is, again, there's more evidence for that. And then this is from Mattia Trivia, who many of you know, and this is based on Charter study. And this is, I won't go into too much detail, but he found that if you look at I think there were 12 biomarkers, as well as a 12-year gap between 2 visits. And the most surprising part was that he found that there are some trait-like biomarkers, meaning that they actually were remarkably stable, especially the CSF biomarkers, that the correlation between baseline and then 12 years later was very, very high. So the ICC was like 0.85 for some of these, including those that we really associate with aging. So like CSF amyloid beta 42, soluble TNF receptor 2, and total tau. Actually, if you look 12 years prior, you can already see the differences in individuals. And so I think this really points, the implications really are that trait-like biomarkers could be used for risk stratification of the progression of cognitive decline, because they do show up so much earlier. And they are so similar between over time in the same people, kind of pointing to more of a genetic or other like genetic predisposition. So this could help with risk stratification. There's a lot more in there, but I will just say that it was very surprising how stable some of those CSF biomarkers were over time. And so then there has been a fair amount of hype or interest in 3TC as possibly a anti-senolytic medication and having neuroprotective properties. This is being looked at in people with and without HIV.
Hey, John.
And hey.
Yeah, I was told by my boss.
Oh, yeah. Okay.
Check the.
Okay.
Work it out.
So 3TC is being considered. Oh, I already told you that part. So what they did was they took 256 people with HIV and on ART, but contained with ART with 3TC versus those without 3TC. And so they looked at a comprehensive cognitive testing and then MRI brain imaging to measure structural imaging. And they adjusted for sex, duration of ART, CD4 count, and intracranial volume to get around size differences. And so they actually found no significant difference in global cognition or specific cognitive domains between groups, which is disappointing in that it doesn't seem like this miracle drug, which is not too surprising since we've had 3TC for a long period of time and we haven't seen that before. They did see some differences in brain structure. So there were some larger frontal lobe volumes in participants receiving 3TC, larger subcortical volumes in the putamen and globus pallidus. It's not entirely clear what these mean, if there is clinical correlation or clinical significance here, but it is of interest. And then they did say like atrophy rates and change was not significantly different. And of course, this is not a randomized controlled trial, so there are differences in prescribing practices of who goes on a 3TC containing regimen versus not. And so it is compounding, but I think it is an important one as that there are no significant differences in people on 3TC, so probably not our miracle drug. So then they looked at dolutegravir. So there is some evidence that, or there was the idea in vitro that dolutegravir could reduce acetylcholinesterase activity in people with HIV. And so this could be associated or part of, they were looking to see if this could explain some of the neuropsychiatric effects that have potentially been associated with dolutegravir. And so it may reduce the activity of acetylcholinesterase in which is involved in nerve signaling and associated with Alzheimer's disease. And it could explain why some people experience sleep or mood symptoms related to dolutegravir. But overall, the difference, so this is the mechanistic evidence, was that it does directly bind to the active site and it inhibits it in vitro. And when they looked at brain tissue findings, they did find some reduced acetylcholinesterase activity in the frontal cortex tissue. It was also noted that they had in the plasma, higher acetylcholinesterase activity was detected in plasma, which all can be consistent with, I guess, possible associations with this, but they were not able to say that there was any Alzheimer's-like changes, and that has not been shown, but it is a signal that is worth potentially highlighting and definitely needs some more research. And then I've only put this in here as the impact of semaglutide on depressive symptoms among people with HIV. So semaglutide does not cure everything, it turns out, but it also does not hurt. So in this study, and this is based on PHQ-9, they looked over, actually, I can't remember over how many weeks it was. Oh, I don't have that in here. But I think it was 24 weeks, but I'm not certain. But overall, even though you see some changes in categories, they did think that this was mostly like regression to the mean, because the people who were high had nowhere to go except for improve, and the people who have no symptoms, obviously some of them will transition to higher, but there was no overall trend of a direction for either increased symptoms or decrease. So generally stable over time. So not bad, not good. And so then and that's kind of all that I found on actually treatment related things. And so really the only, I think, positive one from that was the low dose hydrocortisone in women. And then, so looking at just other kind of biomarkers and pathogenesis, and it is also along the theme of treating treatable traits, is so MASH and progression of cognitive decline in older people with HIV, so a prospective study. So they did look at people over 50 years old in different cohorts. And they looked, so MASH definition was the FAST score. So it was based on the FibroScan plus AST, basically. And then cognitive assessment, it is notable that it was just MoCA score, so a very clinically relevant score and implementable score, but not the most sensitive. And then they defined cognitive impairment as less than 25 on the MoCA. So overall results, interestingly, so they do say that MASH was independently associated with accelerated cognitive decline in older people with HIV over a 6-year period. And so highlighting the importance of identifying and managing MASH in people with HIV. So that's true across the board, whether we're talking about neuro or not. But I think it is interesting that if you look a little bit deeper, so the baseline MoCA scores between people with and without MASH was not different. And the similarly cognitive impairment at baseline with MASH or no MASH was not different. It was only the change, so basically only the trajectory. So if you had MASH diagnosed at baseline, whether you were impaired or not, you were at higher risk of decline, which I think makes sense, but I also would have expected the baseline. If you already have MASH, I would have expected a signal for worse cognitive function, but they did not find that. So it highlights the possible intervenable treatable trait in this one. And then depression and inflammation in this, and this is in acute HIV specifically. And so they did find part of it was looking to see if you look at the different domains of depression, which we don't often do, but it's certainly an increased trend and interest right now. And so they divided so this is still just based on PHQ-9, but basically on externalizing, internalizing, arousal, regulatory, and then cognitive and sensory motor domains. So looking at the different basically subtypes of depression symptoms and trying to see differences in etiology. And so what they did find was that actually TNF receptor 1 was a key marker, and it was actually significantly associated, so higher in all 4 depressive symptom domains versus people who did not have depression. And viral load was specifically linked to externalizing, so mood and energy and cognitive complaints, which is, I think, not particularly, especially the energy and the cognition is not too surprising, but also specifically the mood complaints. And then symptom severity. So if you have a cutoff of especially greater than 15, but there was a trend level significance at greater than 10, higher depression severity was associated with more elevated inflammatory markers. So this did start to include neopterin, IP-10, IL-6, basically. So overall, higher inflammation, higher depression severity. And then, oops, I guess that one got cut off. But basically, I'll tell you what it says. So let's see if I remember. So different patterns of depressive symptoms in early HIV are biologically linked and show distinct inflammatory and viral burden signatures. So interesting, but remember, it is an acute HIV, but I think the key takeaway here was that it is easy to say in acute HIV, you expect people to be depressed because they've just had a major life-changing diagnosis, and it is depressing. And so people have often just said that you expect people to be depressed. It's not biologically are related to the HIV itself. It's just the stigma and the kind of adjustment component. But these do show that it was associated with higher inflammatory markers. Of course, it does not show directionality. So you can also have depression leading to increased inflammation. And then this is one by yours truly and Dr. Latender. So this is latent herpes virus infections influence the cerebrospinal fluid profile of people with HIV. So this is looking at, with the rationale being that multiple herpes viruses have been linked to dementia risk. And this was kind of a convenient sample of, we had some biomarkers in a subset of people that we had measured CMV and EBV IgG levels on, and also had CMV, EBV, and HIV cellular DNA quantified. And so we were looking to examine the associations between these blood-based biomarkers or markers of CMV, EBV, and HIV activity and immune response, and then compare that to cerebrospinal fluid biomarkers known to be associated with neuronal injury, inflammation, and like amyloid pathology. And this is all in virally suppressed people with HIV. And so it's 107 people, mean age about 55 years. And everybody was EBV seropositive and 94% were CMV positive. And then for the viral measures, so this is cell-associated DNA measured by ddPCR in PBMCs. And then the IgG is just a quantitative commercial assay, ELISA assays, and that's for CMV and EBV. And then the CSF biomarkers are neurofilament light, soluble TNF receptor 2, total tau, A beta 42, MCP1, IL-6, and then other inflammatory and oxidative stress markers. And so, interestingly, we did see that there was significant associations between CMV and soluble TNF receptor 2. And I guess here's this whole little table, but kind of the key takeaway is that it looked like there were different effects with different biomarkers and CMV versus EBV. So EBV markers seem to be more correlated or associated with markers of more direct neuronal injury. So like increased NFL, increased tau, and so CSF, NFL, and CSF tau. And then CMV was more, it seemed a little bit more indirect of increased neuroinflammation, so increased CSF, soluble TNF receptor 2, which has been shown to be increased in people with CMV and does change over time with letermovir treatment. So it does seem that it is causally related to CMV. And then I think interestingly, the amyloid processing and clearance, there was kind of a mixed picture associated with CMV in that increased amyloid beta 42 was associated with higher CMV IgG and also CMV DNA. And so this is actually increased A beta 42 in CSF is actually usually considered a good sign or protective. And then, but also increased amyloid precursor protein, which is typically bad. So there's some conflicting information with these CMV associations here, which could be related to, it definitely needs to be validated in a larger cohort. But if it is validated, there's more investigation that should be done looking at truly like amyloid processing, and maybe it affects the ability to clear amyloid from the brain, and possibly CSF, and then also possibly alterations in amyloid processing. And so the key takeaway is basically that there's some distinct CSF biomarker relationships in biomarkers specifically related to neurodegeneration and neuroinflammation. And some of the, I guess, biomarkers that we have looked at and found significant associations with more traditionally in the past, so like the neopterin, MCP1, IL-6, and soluble CD14, that there's a lot of data associating those with neurocognitive impairment in people with HIV. It does seem that that's possibly mostly in people who are off of ART and viremic. And so we are starting to see a little bit of shift here in looking at the neuronal injury. And of note, HIV DNA in PBMCs was not associated with any of these. There was a trend level significance with MCP1, but none of the neurodegeneration markers. And then I think many of you may know Kalen Peterson. He was a STAR scholar, and he's at St. Louis. And so this was showing the Grimm age clock, so one of the epigenetic markers or clocks, corresponds to accelerated brain aging and executive dysfunction in people with HIV. And so this is one of the validated epigenetic clocks related to mortality and morbidity. And it did show, so let's see down here. So in the bottom left corner here, this is executive function on the x-axis and the Grimm age on the y-axis. And the red is people with HIV, and the black lines are people without HIV. And so you can see that overall, the kind of associations or the slopes look somewhat similar, and that higher Grimm age is actually associated with worse executive function. But he does point out that social determinants of health also have a very, even perhaps more significant association. So this is the Grimm age with the area deprivation index. So this is basically a neighborhood level mapping tool that ranks multiple components of socioeconomic disadvantage. And so in both people with HIV and without HIV, there is a significant association, although it does look steeper with people without HIV. And then similarly, or not similarly, but education also does show a significant protective effect in this Grimm age calculation here. And this is fairly similar for people with and without HIV. And I think overall takeaway for me here was that it is, the Grimm age is a good and validated clock of kind of biological age. And there are some associations with some cognitive function, including executive function, but the things like social determinants of health and education actually play an even larger role. And then this is also by UCSD associated people. So Azine Tabasoli and Dr. Ellis. So links between gut metabolites, insulin resistance, and cognitive impairment. And so this was a large metabolomic data set and in 200 people. And this was stratified by diabetes status, just to try to get a better sense there of what was diabetes and what was HIV. And so this did have 100 people with HIV and 100 without HIV. And so the metabolic vulnerability was what they have called it. So they looked at kind of the insulin resistant indices, and this may predict worse scores. in people with HIV, which they only noted the correlation in people with HIV, and then higher plasma betaine levels were significantly associated with better cognitive outcomes and also with lower insulin resistance. So it could possibly be a mediator between those two. And they suggested betaine supplements and gut microbiome modulation could be therapeutic targets. And I have completely blanked on what betaine was, but we looked it up. Is Dr. Ellis here? He's not. Okay. Well, it will either come to me or somebody will tell me. But it is not a readily available supplement as far as I can remember, or I'm assuming azine's not on here either. But it is worth further investigation, basically. And then this was a larger proteomic data set correlating with depressive symptoms. And so this was to understand if you could find biomarkers during, and this is again during acute HIV, and seeing if they're associated with longitudinal depressive symptom trajectories. And so first, what they did was they used machine learning and they did clustering. And so they clustered participants, and they found that basically cluster 3 was, and this is represented in this little graph in the corner here. So green is cluster 3 that have basically persistently or reliably low PHQ-9 total scores, versus cluster 2, which is they had remitting symptoms. So initially they had elevated PHQ-9, but it got better, versus cluster 1 was persistently kind of above some threshold, although I believe it was always above 8, which is not quite a traditional cutoff here. But so overall, I keep doing that. Persistently high. 1 second. Can you guys hear background noise?
Nope.
Okay, great. So persistently high and remitting depression clusters differed from the persistently low, with signatures related to inflammation. So inflammation, and I would say, and they said metabolic reprogramming, but I'd also say metabolic reprogramming and oxidative stress. And they were independent of age, plasma viral load, and stimulant exposure. So I think some additional biological data for inflammation and the association with depression, meaning that, which is pointing to a whole direction to take depression treatment, perhaps. And then my time check here.
Yeah, sorry, I was just about to give you the 8:45.
Okay. So I have more slides on my other poster, which I like to talk about, but I will do it in 5 minutes or less. And so this was a kind of overly convoluted name of panviral antibody reactome profiles associated with cognition in people with HIV. But what it really is looking at is a epitope-specific antibodies to all known viruses. So about 286,000 different specific antiviral antibodies. And this is using a DNA bar-coded viral peptide. So it's a high throughput assay. And this is only 88 people. We'll soon have 176 any minute. of ART suppressed people with HIV will be from the H and RC cohort. And everybody had plasma and CSF viral loads less than 200. And this is cross-sectional, as I said, and we looked at global and cognitive impairment in 7 domains. And so, oh wait, do I not? Ah, well, that's terrible. I thought I brought more information here, but okay. So what I will just summarize, I don't know what happened. Oh, here we go. Okay, never mind, I do. So overall, the cohort's kind of about 55 years of age. It is worth noting that about 20% women only, and that we do have, for ethnicity, about 27% have Hispanic ethnicity, and then it is mostly white, but about 23% Black. And overall, pretty good immune reconstitution with people with a CD4 count, current CD4 count of 680. And then overall, the most significant associations were seen with working memory impairment. And so what the volcano plot is on the right here is the ones on the right are individual antibodies associated with impairment. And then on the left are individual antibodies associated with that are higher in unimpaired people. And so I think I did say that this is working memory. So working memory in plasma and CSF did show those most significant associations, and they were very similar, but CSF did have stronger associations. And it was the only domain that had significant associations after FDR correction. And so what the colors here are highlighting were kind of the viruses of interest that I wanted to look at first. And so the blue is HIV, and then the other colors are different herpes viruses. And so what I think is most notable and is similar in many other domains is that HIV has both, this is a misnomer, but I'm going to say both protective, so associated with unimpaired, and also risk associated, so higher and unimpaired, which is the higher and impaired is in red here, and all of the blue dots are HIV. And so interestingly, almost all of the blue ones here are HIV specific antibodies are to different parts of the envelope protein, whereas even though you can't see a lot of the blue dots here because they're kind of covered, there still are a lot here that they're mostly non-envelope proteins. And then I think also particularly interesting was that the herpes viruses, we had expected both them to be split similar to HIV with some higher and impaired and some higher and unimpaired. But what we found was almost all or all of the specific kind of antibodies that were associated with impairment or unimpairment at all were actually higher in unimpaired people. And this holds up even when you correct for CD4 nadir and duration of infection and other and age. So it was a little bit surprising, but it has been also shown in other cohorts with dementia, specifically in people without HIV. So it is reasonable. And then just one last little slide here would be, this was kind of summarizing basically the results from the volcano plot, or actually from the little bar chart below that I had just shown, but this is for each different domain. And so overall and then on the this part here is the viruses of interest. And I also added HBV because there were a significant number of HBV specific antibodies that were associated with working memory, executive, and verbal. And again, like we had seen with the herpes viruses, it was almost all associated with unimpaired. So I'm in the process of looking to see if that has to do with possibly with vaccination or immunization. But I think the biggest takeaway was, my research is really focused. Sorry, the mouse is kind of getting crazy. So overall, the biggest takeaway was, even though I was really interested in the co-infections and the immune response to other viruses, the number of differentially reactive virus antibodies was by far and away most significant for HIV antibodies. So you can see that the size of the circle here is the number of differentially expressed antibodies. And then the coloring here is basically the mix between higher and unimpaired and higher and impaired. And HIV is the only one that really has a good mix, or has more that are kind of risk associated or risk markers. And so I will overall kind of end there, but basically this is the preliminariest of my preliminary stuff for my KL2. And I would say, and I was excited about it, but everybody else is more excited about the other biomarker study. But I will say, I will end there and open it up for questions. But thank you to everyone who helped with this. And of course, all of the study volunteers who make all of it possible. Okay.
Thank you so much, Katie. I did look up the
Baytime.
trimethylglycine compound found in foods like beets. Supplements reduce homocysteine levels, support liver function, boost exercise performance. That was my, quick search.
Perfect. So everybody eat beets.
I think we've known that for a long time.
I think so.
Gigi unmuted. I was going to read your question, but Gigi, I don't know if you have other things that you wanted to ask about. I don't know if she realized.
No.
Oh.
Sorry.
It's okay. Well, because I think you have two. I think you must have opened up two things. Anyway, Gigi had asked earlier when you were talking about, I think you were talking about Alzheimer's. Are amyloid and tau elevated in anything else besides Alzheimer's? We were just talking about, dementia in general. And I don't know if you know that.
Tau can be. It can be just elevated in overall neuronal injury for other reasons. And I think both amyloid and tau can be elevated in other neurodegenerative diseases, but generally they are considered neurodegenerative markers, but I'm not aware of them being associated with anything other than, I guess, cognitive or some sort of neurodegenerative disease. But if we have any neurologists on here, please jump in. Okay.
Aaron had brought up that his patients seem to exhibit. Oh, go ahead, Aaron. Thank you. Sorry, I didn't know if you were able to unmute.
Thank you, Dr. Riggs. We have a little watch party at Owen Clinic this morning, and each time a new study came up, we had a lot of good conversation here. But one of the things I wanted to observe or make comment to was the study you presented on the GLP-1 and depression symptoms. I've certainly thought about the effects of GLP-1 inhibitors on the brain, but I've never really thought about depression or measuring depression. So I was really interested in that study. And one of the thoughts that I had is that I've not really noticed or anecdotally noticed any changes in patients when they start GLP-1 inhibitors, but they get very anxious and or depressed when their insurance changes or the insurance coverage changes and it has to go away. And I think that's an experience for any medication. but it seems to be a little more with the GLP-1 inhibitors. And I don't know if it's just related to, multifactorial, other things going on, or if there's something on the brain that gets met with the GLP-1 inhibitors and then like abruptly taken away instead of tapered down, how we do with like rebound
Yeah.
hypogonadism or something like that. It's just anecdotally the depression symptoms are more with an abrupt stop of these medications. Did the studies look at stopping the GLP-1 inhibitors at all, or just the effects of
No.
starting one of these medicines?
Yeah, it was just basically like starting at baseline and then after, I think it was 24 weeks. So I didn't see anything about stopping, but that is definitely interesting because, yeah, you're right. I would immediately assume like, oh, it's just the anxiety that, they're not going to be able to continue weight loss. But we do know that there are some effects on brain, and that would be very interesting to look at. I guess, unfortunately, we have quite the cohort we could look at now.
I don't know how you would study that. I don't know how you would
Yeah.
tease out all of the different factors that go into that.
Yeah.
It's
Sure.
it's really interesting though, Erin.
I mean, you could track the same measurements, the PHQ survey data, qualitative
Yeah.
data. I don't know that you could, because there's so many other things socially around abruptly
Right.
stopping a medication.
Yeah.
But you could at
Well,
least identify an association.
Like you'd have to control for weight gain, because I think for a lot of people, right, that's the big fear. They're gonna gain the weight back. And that to me, this is it's hard to know. I obviously couldn't say for sure, but it does seem like the impact that it's had on people's weight loss and other positive effects is so dramatic, and there's really nothing like it that's ever been like it
Yeah.
in years.
Yeah.
But then thyroid, I think their depressive symptoms precede the weight gain once they stop.
Yeah, I guess the weight gain is a bit delayed once they
I
stop.
don't know. We're all just, it would be really interesting to study. So Katie, get to it.
Okay. I mean, you can always just do like a quick analysis just to see if after stopping depression scores go up. And then if they do, you can do a stronger study.
Right. I mean, it would definitely be interesting to look at even just something simplistically from our cohort.
Yeah.
Yeah.
And then Medi-Cal would have to pay for it.
Oh, yeah.
Just kidding.
Oh, don't make me laugh.
I know. Okay.
Katie, this was great. Such a comprehensive review of all things neuro at CROI. I assume people will be able to access your slides, and obviously this was recorded. So thank you so much.
Well, thank you guys. I appreciate it. And thanks for the questions and ideas. And of course, it wasn't all things neuro because I left a lot out, but it is good. And if you do want to watch anything, watch
neuro. Yeah.
Yes, watch Shabani Mukherjee's 20-minute thing on assessing in the clinic if you want to watch more.
Thank you so much. Bye, everyone.
Yes.
Have a great
Thanks,
weekend.
guys. Bye.